Welcome back to the deep dive. Today we're shifting gears completely. We're leaving the casual conversation at the door. We're stepping right into the exam hall.
That's right.
I want you to just close your eyes for a second. Imagine you're sitting in that stiff wooden chair. The air conditioning is humming, your palms are, a little sweaty, and across the table sits a senior professor.
The one with the thick glasses and the red pen.
Exactly. And they're just waiting for you to slip up.
Yeah.
You are a postgraduate student, an MD in anesthesiology, and you are staring down the barrel of your final exams. And we're specifically targeting, well, the rigorous curriculum standards you'd see in a place like Gujarat University.
That's right. And for today, I am stepping into the role of that, shall we say, terrifying senior MD faculty member. My job isn't to hold your hand, it's to drill the exam gold into your head. We're going to be clinical, precise, and absolutely ruthless about what you need to know to pass.
The topic on the table today is a classic. It's cleft lip and cleft palate. Now, to the uninitiated, this might sound like a plastic surgery topic, but you're telling me this is actually the final boss of pediatric anesthesia exams.
It absolutely is. I mean, look, if you get this case in a long question or a Viva, you should actually be happy.
Happy.
Well, happy, but also very afraid. It's your chance to shine, but it's also a minefield. It is the quintessential pediatric anesthesia case study. It combines the difficult airway algorithm, the unique physiology of a neonate or infant, and that classic shared airway workspace.
Where you and the surgeon are basically fighting for real estate.
Precisely. You're both trying to work in a space the size of a postage stamp. And on top of all that, there's a huge potential for congenital syndromic associations. If you treat a cleft palate like a routine hernia repair, you will fail. It's as simple as that.
And to tackle this, we have a massive stack of sources. We're drawing from the Bibles, of course, Miller's Anesthesia, Morgan and Muckile, Smith's Anesthesia for Infants and Children.
Cornerstones.
But we also have what you call the clinical exam secret weapons books, like long and short cases in anesthesiology and ESDAS clinical surgery.
Those clinical case books are vital. They're absolutely vital. They tell you what the examiner actually wants to hear, not just the dense theory. Our mission today is to convert that textbook density into a Viva-ready audio guide. We're going to structure this exactly how you should structure a long answer in a written paper.
Okay, let's do it. Let's jump straight into Part A, Introduction and Exam Framing. If I'm the student and the examiner asks me, just flat out, define the topic, where do I even start?
You start with absolute precision. No vague, hand-waving answers. Cleft lip, or CL, is defined as a failure of fusion of the maxillary process with the medial nasal process.
Okay, maxillary and medial nasal, not lateral.
Not lateral. That's a common mistake. They'll catch you on that. It is the maxillary and the medial nasal. That is the specific anatomical failure.
Got it. And for cleft palate?
Cleft palate, or CP, is a failure of the palatal ridges. You'll also hear them called the palatal shelves, to migrate medially and fuse in the midline. It's another failure of fusion, but a different mechanism and a different timeline.
Okay, definitions are set. Crystal clear. What about the numbers? Examiners always love to ask for incidence rates.
They do. You need to have these ready. Quote, that cleft lip, with or without cleft palate, occurs in approximately 1 in 1,000 live births. It's fairly common.
And isolated cleft palate.
That's rarer. Isolated CP occurs in about 1 in 2,500 births.
And is there a demographic breakdown we need to know? I feel like there's a trap here, maybe regarding gender.
There is a massive trap. It's one of their favorites. They will ask, is it more common in boys or girls? And the answer depends entirely on the anatomy. This is crucial.
Okay, so break it down for us.
Cleft lip, and that includes with or without the palate being involved, is more common in boys.
Okay, lip is for boys.
But isolated cleft palate, that is more common in girls.
Why the difference? I mean, embryologically, what's going on there?
Well, it likely relates to the timing of palatal closure. In embryology, that process is slightly delayed in females compared to males. It just leaves a longer window, a longer period of vulnerability for environmental or teratogenic insults to disrupt the fusion.
So for the Viva, I don't need to explain the whole mechanism, just the fact.
For the Viva, just remember, lip equals boys, isolated palate equals girls. Do not mix those two up. It's a simple point, but getting it wrong shows you haven't done your homework.
What about racial variation? Is that an exam-worthy point?
It is. It shows breadth of knowledge. It's highest in Asian populations, about 1.6 per 1,000. It's lowest in African-American populations. Caucasians fall somewhere in the middle.
You mentioned earlier why this is such a hot topic for anesthesia. Can we just elaborate on that? Why this over, say, a pyloric stenosis?
Because it tests everything at once. It forces you to demonstrate that you can handle a shared airway. Like we said, you and the surgeon are competing for the same 3 square inches of space in a tiny infant's mouth. You have the endotracheal tube, they have the ding-man gag, and you're both working in a very vascular area. It's high stakes.
And it's not just the airway.
Not at all. It forces you to demonstrate that you understand syndromic children. A cleft is so rarely just a cleft. It's often a signpost, a clue that there are other, more sinister things going on with the heart, the spine, the entire craniofacial structure.
So, wrapping up this intro section, what are the typical question patterns we might see in the exam paper?
You might get short notes on something specific, like anesthetic management of Pierre sequence, which we'll cover in detail, or postoperative complications of palatoplasty.
And the big one.
The big one, the 10 to 20 marker, will be a comprehensive case. Something like, describe the embryology classification and anesthetic management of a 10-month-old child for cleft palate repair. That is the exact question we are essentially answering today.
Okay, that sets the stage perfectly. Let's move to Part B, embryology and classification. I have to admit, a lot of residents, myself included, tend to gloss over the embryology. But you're saying it's essential.
It is absolutely essential. I cannot stress this enough. If you cannot explain the embryology, you lose all credibility with the examiner immediately. It's the foundation of everything else. You need to divide it by anatomy and by timing.
Okay, so give me the timeline first. What happens when?
The face develops very early. We're talking between weeks 4 and 7 of fetal life. That's when all the facial processes are migrating and fusing.
And the palate?
The palate develops later. The secondary palate fusion occurs between weeks 7 and 12. This difference in timing is key to understanding why you can have an isolated cleft palate without a cleft lip. The lip has already formed successfully.
Let's dig into the mechanism. You mentioned the lip is a fusion failure of the maxillary and medial nasal processes. What about the palate? I've heard the drawbridge analogy used for this.
That is the best way to visualize it. I use it all the time. In the early fetus, the tongue is relatively huge compared to the oral cavity, and it sits high up, actually, in the nasal cavity.
So it's physically in the way.
It's physically in the way. The palatal shells are hanging down vertically on either side of the tongue like 2 flags. They're just stuck.
So for the palate to form, the tongue has to move.
Exactly. Around weeks 7 or 8, a few things happen. The neck extends, the mandible grows forward a little bit, and this allows the tongue to drop down out of the nasal cavity and into the mouth.
And that frees up the shelves.
It frees them up.
Yeah.
This allows the palatal shelves to swing upward, just like a drawbridge raising, and then they fuse in the midline. First they fuse with each other, and then they fuse with the nasal septum from above.
So if the tongue doesn't drop for some reason,
the shelves can't fuse. They literally hit the tongue and stay open. And that is the fundamental mechanism of the cleft palate in Pierre sequence, which we will discuss later. The small jaw, the micrognathia, keeps the tongue high, physically blocking the palate from closing.
you mentioned a specific anatomical landmark that you called a mandatory passing point.
The incisive foramen. You must identify this in your answer. It is the anatomical boundary that separates the 2 parts of the palate's development.
Okay, so what is anterior to it and what is posterior?
Anything anterior to the incisive foramen, that's the alveolar ridge and the lip, is considered the primary palate. Anything posterior to it, the hard and soft palate, is the secondary palate.
That's a fantastic distinction, and it leads perfectly into classification. How do we classify these anomalies for the exam?
Keep it simple. Keep it anatomical for cleft lip. First question, is it unilateral or bilateral?
Simple enough.
Second question, is it complete or incomplete? A complete cleft extends right into the floor of the nostril, creating a direct communication. An incomplete cleft implies there's a bridge of skin, which is sometimes called Simonart's band, or it might just be a small notch in the vermilion border.
Okay. And for the cleft palate?
Again, related back to our landmark. You can classify it as prepalatal, affecting the primary palate, or postpalatal, affecting the secondary palate, or, of course, a combination of both.
But you said there was a third type we absolutely must mention.
Yes, the submucosal cleft. This is the hidden threat.
Why hidden?
Because the mucosa, the skin overlying the palate, is intact. So at a quick glance, the palate might look normal, but underneath, the muscles have not fused, and there's often a bony defect in the hard palate.
So how do we spot that in a pre-op check? If it's hidden, what are the clues?
You look for the classic triad, which is an absolute Viva favorite.
Yeah.
1, a Bifid uvula. The uvula at the back is split in 2, like a little fishtail.
Okay.
2, a Zona Pellucida. This is a thin, almost bluish-looking strip in the midline of the soft palate. It's translucent because there's no muscle underneath, just mucosa.
And the third part of the triad?
A palpable notch. You can actually feel a V-shaped notch in the posterior border of the hard palate where the bone failed to fuse.
So as the anesthesiologist, why do I care so much about a submucosal cleft? We aren't the ones fixing it.
You care because of the risk of velopharyngeal incompetence, or VPI. This is a huge deal. The muscles of the soft palate aren't working correctly. Now, imagine that child with their undiagnosed submucosal cleft goes for an adenoidectomy later in life.
I see where this is going.
If the surgeon removes the adenoid pad, which was actually helping to plug the gap, you can completely unmask the VPI. You can ruin their speech mechanism. They will have terrible nasal regurgitation and hypernasal speech forever. It is a major medical legal pitfall, and the anesthesiologist is often the first person in a position to spot it.
That's a crucial point. Now, anesthetically, does the classification say unilateral versus bilateral change our actual airway approach?
Drastically. A bilateral cleft lip in particular often comes with a protruding premaxilla. That's the central piece of the gum and bone that holds the incisor teeth.
And it sticks out.
It sticks right out, often on a stalk of tissue. During laryngoscopy, your blade can fall into the cleft gap on either side, giving you no purchase, or the premaxilla itself can physically block your view of the vocal cords. It is a major predictor of a difficult airway.
Okay, this is making a lot of sense. Let's move to Part C, associated problems and preoperative assessment. This feels like a section where we stop looking at the hole in the lip and start looking at the entire patient.
Correct. And the rule of thumb you must state in the exam is this. Isolated cleft lip is usually just a cosmetic issue. It's often an isolated finding.
Not the palate.
But isolated cleft palate is often syndromic. It is associated with other congenital defects in 30 to 50% of cases. It's a huge difference.
So if we see a palate, we go hunting for other problems.
Mm-hmm.
What are the big three syndromes we need to have on our fingertips?
Number one, without a doubt, is Pierre-Robin sequence. And note that I said sequence, not syndrome. An examiner will appreciate that distinction. It's a chain of events, not a single genetic cause.
Walk us through that chain again.
It starts with Micrognathia, a tiny, underdeveloped mandible or lower jaw. This small jaw forces the tongue to be displaced posteriorly and superiorly. That's called glossoptosis. The tongue literally falls back into the pharynx.
And that tongue falling back is what causes the other problems.
Precisely. The tongue physically prevents the palatal shelves from fusing, which causes the U-shaped cleft palate. And most importantly for us, the tongue falls back and obstructs the glottis, causing severe airway obstruction.
And the anesthetic implication here is?
It is an airway nightmare. That's the phrase to use. The tongue falls back and obstructs everything. Upon induction of anesthesia, when all muscle tone is lost, you often cannot ventilate the child by mask, and you cannot see the cords to intubate. It's a can't intubate, can't ventilate scenario waiting to happen.
Okay, that's number one. What's the next syndrome on our list?
Treacher syndrome, which is also known as mandibulofacial dysostosis. These kids have characteristic facial features: malar hypoplasia, which means flat cheekbones, downward slanting eyes, and often ear abnormalities, which can include hearing loss.
And the airway.
The airway is also extremely difficult. But the terrifying thing about tracheopollens, and this is a key differentiator from Pierre-Robin, is that the airway often gets worse with age as their abnormal facial structures grow.
Whereas the Pierre-Robin kids can sometimes improve.
Exactly. With Pierre-Robin, the mandible can sometimes have a bit of catch-up growth, which pulls the tongue forward and opens up the airway. Not so with Treacher. They are a lifelong airway challenge.
And the third major one?
Velocardiofacial syndrome. This is associated with the 22q11 deletions. You might see it called that. It's also known as DiGeorge syndrome. The name itself tells you the risks.
Velocardiofacial.
Velo for velum, the soft palate, they have palate issues. Cardio for heart, they have a very high incidence of cardiac defects. And facial for the dysmorphic features.
What kind of cardiac defects are we talking about?
Specifically, you need to mention conotruncal defects, things like tetralogy of Palate, truncus arteriosus, or an interrupted aortic arch. These are serious, and you must have a pre-op echo and cardiology consult.
The source material also mentioned an immune deficiency in DiGeorge. Can you expand on that?
Yes, that's a very important point. They can have thymic aplasia or hypoplasia. The thymus is crucial for T-cell development. This leads to a T-cell immune deficiency.
So they are prone to infections.
Prone to unusual and severe infections, yes. And it also means you have to be careful with blood transfusions. They may need irradiated blood to prevent graft versus host disease.
And there's one more piece to DiGeorge, isn't there? Something about calcium.
Hypocalcemia. The parathyroid glands can also be underdeveloped. This can lead to low calcium levels. So if a DiGeorge kid starts to seize on induction or in recovery, don't just think about hypoxia. Check the calcium.
Okay, that's a huge amount to consider. Apart from these major syndromes, what are the more general systemic issues we see with these children?
Feeding. Feeding is the big one. They have nasal regurgitation because there's no separation between the mouth and nose. And more importantly, they can't create the negative pressure needed to suck effectively from a breast or a bottle.
And that leads to?
Failure to thrive. It's a classic triad. You will often see malnutrition, anemia from poor intake, and chronic dehydration. They come to you in a fragile state.
What about infections?
Chronic infections are the norm, specifically recurrent upper respiratory infections or URIs and otitis media.
The ear infections, right. What's the mechanism there?
The muscles of the cleft palate, specifically one called the tensor veli palatini, are responsible for opening the eustachian tube to drain the middle ear. In a cleft, these muscles don't work. The tube stays shut, the ear fills with fluid, and it gets infected over and over again. Many of these kids will get grommets placed at the same time as their palate repair.
Okay, so bringing all of this to the preoperative assessment. When this child arrives in the pre-op bay, what are we specifically looking for?
Airway, airway, airway. That's your mantra. Look for micrognathia and retrognathia. Is the jaw small and set back? Check for that protruding premaxilla we talked about. Open the mouth, look at the size of the tongue relative to the mouth, and then you ask the parents about the snoring history.
Why is snoring so important?
Does the child snore? Do they have apneic pauses during sleep? Do they desaturate during feeds when they have to coordinate breathing and swallowing? A positive answer to any of these questions indicates obstructive sleep apnea or OSA.
And an OSA child is a high-risk anesthetic patient.
Exquisitely so. They are exquisitely sensitive to the respiratory depressant effects of opioids and sedatives. If you give a child with significant OSA a standard dose of fentanyl, they might just stop breathing in the recovery room. You have to be incredibly cautious.
What about labs? The sources mentioned very specific hemoglobin cutoffs.
Yes, and exams love specific numbers, so you need to know these. For cleft lip repair, the generally accepted minimum hemoglobin is 8 grams per deciliter.
8 for the lip.
But for cleft palate repair, it is strictly 10 grams per deciliter.
And why the difference? Why do you need more hemoglobin for a palate repair?
Because cleft palate surgery is much, much bloodier. For a lip repair, you're mostly dealing with skin and muscle. For a palate repair, the surgeon is stripping large mucoperiosteal flaps off the bone of the hard palate. The risk of significant blood loss is much higher, so you need a better starting reserve.
Got it. And what about the classic runny nose? These kids always seem to have a cold. When do we cancel and when do we proceed?
That is the eternal dilemma in pediatric anesthesia. You have to differentiate between chronic, clear rhinorrhea from nasal regurgitation and a true active infection. The rule is this. If there is fever, a productive cough with yellow or green sputum, or any chest signs like rhonchi or crepitations on auscultation, you cancel. Full stop.
And how long do you wait?
You wait 4 to 6 weeks. That's the time frame needed for the airway hyperreactivity to settle down. Going ahead with an active URI is just asking for laryngospasm, bronchospasm, and post-op desaturation.
Let's talk about timing of surgery. You hear about the rule of tens. Is that still relevant?
It is. It's a classic concept, and you should mention it. It applies primarily to the timing of cleft lip repair. The rule suggests that surgery is safest when the child is at least 10 weeks old, weighs at least 10 pounds, and has a hemoglobin of at least 10 grams.
But you said the HB cutoff for lip was 8?
You're sharp.
Yep.
Yes. The original rule said 10, but modern practice, as per many sources like long and short cases, often accepts 8 for a lip repair. The 10-pound and 10-week part is more about general physiological maturity. It ensures the child has survived the fragile neonatal period, and any major cardiac lesions have had time to declare themselves.
So in practice, when is the lip done?
Generally, cleft lip is repaired at 3 to 6 months of age.
And the palate, why is that later?
Palate repair is usually done later, between 9 and 18 months of age. The logic here is a trade-off.
A trade-off between what?
You want to wait for the airway and the oral cavity to grow larger, which makes the surgery technically easier and anesthetically safer. But you must repair it before speech development really takes off, around 2 years of age. If you wait too long, they will develop permanent compensatory speech defects that are very difficult to correct.
Last question on pre-op, pre-medication. Do we sedate these anxious kids and their parents?
You have to be very, very careful. In a non-syndromic child with a simple cleft lip, A small dose of oral midazolam might be acceptable. But in a syndromic child, like a Pierre, heavy sedation can cause total airway collapse.
Because they need their muscle tone to keep the airway open?
Precisely. They depend on that awake muscle tone to keep the tongue pulled forward. Sedation relaxes those muscles, the tongue falls back, and you have an emergency before you've even left the pre-op area. Generally, we avoid sedatives in the ward for any child with a suspected difficult airway.
But what about antisalagogues? Drugs to dry up secretions.
Now, that is a good idea. Using an antisalagogue like glycopyrrolate is often very helpful.
Why specifically?
A mouthful of saliva and secretions makes a difficult airway nearly impossible. If you are planning an awake fiber optic intubation, or even if you're just using ketamine for induction, which can increase secretions, having a dry field is a massive advantage. So yes to glycopyrrolate, but a big maybe or no to sedatives.
Excellent. Okay, that was a very thorough pre-op section. Let's move on to Part D, anesthetic management. Specifically for cleft lip, what are our primary goals here?
For the lip, the mission is pretty focused. Goal number 1 is to secure the airway without distorting the surgical field. The surgeon needs to see the symmetry of the lip, the Cupid's bow, the philtral columns. If you tape the tube to the side they are repairing, or if your tape pulls the lip, you compromise their repair.
Okay, symmetry is key. What else?
A rapid, smooth awakening. You want to avoid coughing, bucking, or straining on the tube at the end, as this can disrupt the fine sutures, and of course, excellent analgesia.
So let's get into the nitty-gritty, induction. How do we get the tube in?
If the airway assessment is completely normal and it's an isolated, incomplete cleft lip, an IV induction is perfectly fine. But in many of these cases, especially with bilateral clefts, we anticipate some difficulty. In that situation, an inhalational induction with sevoflurane is the gold standard.
Why is SIVO over Fafurth?
Because it allows you to maintain spontaneous ventilation while you secure the airway. You can deepen the anesthesia gradually. If you hit a snag, if you find you can't mask ventilate or can't see the cords, you can just turn off the gas, let the child breathe it off, and wake them up. You haven't burned any bridges, which you would have if you'd given a muscle relaxant.
And the tube itself, the sources are very specific about using an RAE tube.
Yes. The RAE tube, named after its inventors Ring, Adair, and Elwin. Specifically for this surgery, you want the South Pole or oral preformed RAE. It has a preformed bend in it that directs the tube down over the chin.
And the reason for that specific bend is critical.
It's absolutely critical for surgical access. It keeps the breathing circuit completely off the face and out of the surgeon's hands. It sits neatly on the chin, giving them an unobstructed field to work on the lip and nose.
But you mentioned a huge trap with these tubes.
The trap is the length. RAE tubes have fixed lengths. The bend is at a set distance from the tip of the tube. In a child with a short neck or a syndromic child with abnormal anatomy, that fixed length might be too long.
So what happens?
You intubate, the bend sits perfectly at the lips where it's supposed to, but the tip of the tube is way down in the right mainstem bronchus. You're only ventilating one lung.
And the solution?
Vigilance. You must listen to breath sounds in both axillae after the child is positioned and the circuit is connected. If you only hear sounds on the right, you've gone too deep. You may need to place some gauze padding between the lip and the bend of the tube to effectively withdraw it by a centimeter or so. Or in some cases, you may have to abandon the RAE and switch to a standard, straight endotracheal tube that you can cut to the correct length.
And fixation of this tube. Where does the tape go?
Strictly in the midline. You can use a log cabin buildup of tape on the chin and then secure the tube to that, or use a dedicated tube holding device. But whatever you do, it must be in the midline to avoid distorting the anatomy. No taping to the cheek.
What if we can't get a seal with the mask during induction because of the cleft? The air just leaks out.
That is a very common induction problem. The air just whistles out of the gap in the lip. You have two simple solutions. First, you can gently pack the cleft with a small piece of moist gauze to complete the seal. Second, you can simply use a slightly larger mask that sits on the solid bone of the cheeks and the chin, bypassing the leaky alveolar ridge altogether.
Let's talk about pain management intraoperatively for a cleft lip. Are we just relying on opioids?
We try to minimize them because we want a quick and alert recovery without respiratory depression. The high-yield answer here, the one that will get you top marks, is to perform a regional block, specifically a bilateral infraorbital nerve block.
Can you describe that technique for the exam?
Certainly. The infraorbital nerve is a branch of the maxillary nerve, and it supplies the upper lip, the ala of the nose, and the lower eyelid. You can block it using an intraoral or an extraoral approach. The intraoral is often easier. You retract the upper lip and inject a small volume of local anesthetic, like bupivacaine, into the buccal sulcus, aiming for the infraorbital foramen.
And where is that foramen?
It's usually located in a straight line down from the pupil, about a centimeter below the inferior orbital rim. You can sometimes palpate it.
And the benefit is a huge reduction in opioid use.
A massive reduction. It provides dense, excellent analgesia right where it's needed. This means you can use less systemic opioid, which leads to a smoother, calmer emergence, less respiratory depression, and an earlier return to feeding. It's a cornerstone of modern management.
Okay, that covers the lip very well. Now let's tackle the beast. Part E, anesthetic management for cleft palate.
Yes, and the stakes are significantly higher here. Everything is more challenging. It's a longer surgery, there is more blood loss, and some degree of postoperative airway swelling is almost guaranteed.
Let's start with the airway challenges that are specific to the palate repair.
Laryngoscopy can be an absolute nightmare. The blade of the laryngoscope, whether you use a Miller or a Macintosh, tends to fall into the cleft gap in the hard palate. You lose your leverage point, you can't lift the epiglottis effectively.
So how do we solve that problem?
There are a few tricks. First, you can do what we mentioned for mask ventilation. Pack the cleft with some gauze to create a solid surface for the blade to rest on. Or you can use a paraglossal approach.
Paraglossal.
It means you go in from the extreme left side of the mouth over the molars. You use the blade to sweep the tongue from left to right, completely avoiding the midline cleft. It often gives you a much better view. And of course, in the modern era, video laryngoscopy has become a game changer for these cases. It takes a lot of the guesswork out.
Once the tube is in and we are ready to start, there is a crucial piece of equipment the surgeon uses called the Dingman gag. Tell us about that.
The Dingman gag, or a similar device like the Boyle-Davis gag, is a self-retaining mouth retractor. It's a frame that sits outside the mouth with a blade that holds the mouth wide open and depresses the tongue, giving the surgeon their view. For the anesthesiologist, this device is a nemesis.
Why is it so dangerous?
For two main reasons. First, the frame and the tongue blade can physically compress the endotracheal tube against the mandible or the teeth, causing a complete obstruction. You might see your end-tidal CO2 trace suddenly disappear the moment they crank it open.
And what do you do?
You must alert the surgeon immediately and loudly, "Stop! Release the gag!" Then you need to find a way to reposition the tube so it's not being compressed. The second reason is more insidious. It's the pressure on the tongue.
It compresses the tongue itself.
For hours, this compression blocks venous drainage from the tongue. The tongue becomes engorged with blood.
And that leads to swelling.
Massive swelling, we call it Micrognathia. After a 2 or 3 hour palate repair, the tongue can be blue, hard, and so swollen that it completely occludes the pharyngeal airway the moment you extubate the child. It can be a catastrophic, life-threatening complication. You must ask the surgeon to briefly release the gag every so often to allow the tongue to reperfuse.
So we need constant vigilance with the gag. What about the throat pack?
This is a zero-tolerance issue in the exam. A throat pack is mandatory for cleft palate surgery. It's a roll of gauze that you place in the pharynx behind the tube to soak up blood and prevent it from trickling down into the stomach or the lungs.
But the danger is forgetting it.
Forgetting to remove it is a medico-legal disaster and an automatic fail in the Viva. It's a never event. If you leave that pack in, the child will have a complete airway obstruction upon extubation and they will die.
So what is the exact phrasing we need to use in the exam?
You say, "I will document the insertion of the throat pack on the anesthetic chart. At the end of surgery before extubation, I will perform a formal check of the pharynx under direct vision and document its removal." You make it a formal, documented step.
Let's talk about maintenance, fluids, and blood loss.
It's a very vascular area. The palate has a rich blood supply. Surgeons will infiltrate with a solution containing epinephrine or adrenaline to help with hemostasis. You need to be aware of the dose they are using and calculate the maximum safe dose for the child's weight. The limit is generally 10 micrograms per kilogram. Watch the monitor for tachycardia or arrhythmias.
And fluid management.
Because the mouth is cranked wide open for hours under a warm operating light, there is a huge amount of insensible fluid loss from evaporation. You need to be generous with your maintenance fluids to prevent dehydration. And you need to meticulously track blood loss on the swabs and in the suction canister and have a clear threshold for when you would transfuse.
Now we come to the most dangerous part of the whole procedure.
Yeah.
Extubation.
We call this the dangerous extubation for a reason. Everything is working against you. The palate, which was a wide open space, is now closed. It's tight and swollen. The effective diameter of the airway is reduced. The tongue might be swollen from the gag, and the pharynx is coated with blood and secretions.
So how do we approach this safely?
There is only one way. You extubate the child only when they are fully awake. Not deep, not in stage 2 fully awake, eyes open, purposeful movement, maybe even reaching for the tube. Their protective airway reflexes must be fully intact.
And what about positioning?
The position is critical. Once you've removed the throat pack and suctioned the pharynx thoroughly, you turn the child into the lateral or prone position. We often call it the tonsil position. This way, if they do vomit or have any residual bleeding, gravity helps it drain out of the mouth rather than back down into the lungs.
What are the specific post-op complications we need to list for the examiner?
Airway obstruction is number 1 from all the causes we just discussed. Laryngospasm is a very high risk because of blood and secretions trickling onto the vocal cords. Then there is the surgical risk of fistula breakdown.
What's that?
If the child coughs, vomits, or cries excessively, they can generate enough pressure to rip the delicate stitches in the palate repair, creating a hole or fistula. So good analgesia and antiemetics are vital. Finally, aspiration of swallowed blood, which is a gastric irritant.
And to stop them from putting their hands in their mouth and disrupting the repair.
We use arm splints. They are often called no sleeves. They are padded splints that keep the elbow straight, so the child simply cannot bend their arm enough to get their fingers into their mouth.
That's a fantastic detailed walkthrough. Let's move to Part F, comparison and integration. This is a classic exam question style. The examiner asks you to compare and contrast the anesthetic management of cleft lip and cleft palate. Give me the table, the cheat sheet.
Here is your cheat sheet for that Viva question.
Lip is early, 3 to 6 months. Palate is later, 9 to 18 months.
Got it.
Second, blood loss. For lip, it's usually minimal. For palate, it can be significant, and you must be prepared for a transfusion.
Okay.
Third, and most importantly, airway risk. For lip, the risk is primarily on induction, the difficulty of laryngoscopy. For palate, it is an induction risk plus a major recovery and postoperative risk due to swelling, bleeding, and obstruction. The danger period is much longer.
That's a key distinction. And what about regional analgesia?
For lip, the infraorbital nerve block is the star of the show. For palate, surgeons often rely on their own local infiltration. Anesthetists can perform greater palatine or nasopalatine nerve blocks, but it's less common and technically more difficult with the gag in place.
And the role of the anesthesiologist in the broader team.
Yeah,
It's not just about putting the tube in, is it?
not even close. You are the perioperative physician. You are the one who has to integrate all the pieces. You are the one flagging the cardiac murmur in the DiGeorge kid and insisting on an echo. You are the one managing the post-op pain and nausea to protect the surgeon's repair. You coordinate with ENT about the ears, with plastics about the face, with pediatrics about nutrition, and with speech therapy about the long-term outcomes. You're the hub of the wheel.
Fantastic. Okay, finally, Part G exam integration. Let's really hammer home the Viva traps. You mentioned the retained throat pack. What else can trip a student up?
The full stomach trap. The examiner might say, this is an elective case, so the child is MPO. Correct. And you'll say yes. Then they'll say, but the child was very difficult to feed and cried for an hour before coming to theater. Is the stomach empty?
And the answer is no.
The answer is no. That child's stomach is full of swallowed air. We call it aerophagia. And it might also be full of milk curds from a feed hours ago that hasn't emptied properly. So you should treat them with the caution of a full stomach. Perhaps consider suctioning the stomach with an OG tube after induction.
What about a recovery room scenario question?
The classic scenario. You are called urgently to the recovery room. The 10-month-old post-cleft palate repair is cyanosed and desaturating. The nurse is panicking. What do you do?
Okay, what's the algorithm?
ABC. But your first thought, your immediate action after ensuring oxygen is on, should be to open the mouth and look. What's the first thing you look for?
The retained throat pack.
The retained throat pack. Someone forget it. Second, is the tongue swollen and falling back? Can you pull the jaw forward? Can you insert a nasopharyngeal airway? But be very careful not to poke the fresh palate repair. Third, is it laryngospasm? Do you hear stridor? Do you need to give succinylmethonium? You have to think through that sequence logically and calmly.
For the written exam, you mentioned diagrams are gold. What should we be practicing drawing?
Practice drawing Kernahan's striped Y. It is a simple Y-shaped diagram that is used to classify clefts. The two arms of the Y represent the primary palate and lip on the left and right. The stem of the Y represents the secondary palate. You simply shade in the segments of the Y that are clefted. Drawing that in your answer sheet shows the examiner you know the classification systems intimately.
And a flowchart.
A simple flowchart for the management of a predicted difficult airway in a syndromic child. For example, Pierre Robin, sequence pre-op assessment confirms Micrognathia-Plan A. Inhalational induction, maintain spontaneous ventilation, attempt laryngoscopy if view is poor, Plan B. Video laryngoscope or fiber optic intubation. Having that structured approach on paper is very impressive.
This has been incredibly comprehensive. Let's summarize the exam gold takeaways one last time. Give us the bullet points.
Rule of tens for cleft lip timing.
Use a south-facing oral RAE tube for surgical access, but always, always check for endobronchial intubation.
Maintain constant Dingman gag vigilance for tube compression and tongue swing.
Throat pack insertion and removal must be formally documented. It's a life or death step.
Awake extubation in the lateral position is non-negotiable for cleft palate repair.
Suspect syndromic association with any isolated cleft palate, and always rule out cardiac issues, especially with 22q11 deletion.
That is a solid exam-winning recap. Before we sign off, give us a final provocative thought to leave the listener with, something to mull over.
We focus so much on the mechanics of repairing the defect after the child is born, but consider the future, fetal surgery. We are already seeing incredible intrauterine interventions for conditions like spina bifida. What if we could repair the cleft lip or palate in utero? The healing would be scarless, the growth potential perfect, but how would that change our anesthetic landscape?
Wow.
You would be anesthetizing two patients simultaneously, a pregnant mother and a tiny fetus. You'd have to manage uterine relaxation to prevent labor, cross the placenta with anesthetic agents, monitor fetal cardiac stability, and then reverse it all. That is the next frontier, and it's both terrifying and thrilling to consider.
That is a fascinating thought, and a perfect place to end. That wraps up our deep dive into cleft lip and palate. With this knowledge, you are now ready to face the examiner.
Good luck. Go get those marks.
And remember to always check your specific university guidelines, as local protocols and curriculums can vary. Join us next time as we dive into another pediatric classic, Tetralogy of Palate. See you then.